Hi, I'm Dr. Sanjeev Sokoling. I'm a psychiatrist and obesity medicine specialist at the University of Toronto and also scientific director for Obesity Canada. And I'm going to talk to you about how health equity or the inequity of social structures impacts obesity care and our risk factors for obesity development. We know there are many factors, biological, psychosocial, that impact and predispose someone to develop obesity, either as a child or later on as an adult. Many of these factors are predominantly around structural and social determinants of health. So, for example, we know that individuals who are struggling financially, who are considered in the lower socioeconomic status bracket of society, who are coming from underserved and communities that don't have access to healthcare or preventative healthcare, or in living in areas where there are food deserts or a reliance on cheaper, calorically dense foods, or have access to irregular meals, may be predisposed to developing obesity. And again, you can think about how these structural and social factors can interplay with one's behavior, but also with one's biology, to think about how they may be predisposed or at higher risk of developing obesity. For example, if people don't have great access to high quality foods or have irregular meals, it can result in nutritional deficiencies, caloric intake that has a propensity for more calorically dense foods or nutrient deficient foods, but also relate to sensitizing our biological reward pathways in a way that might precipitate disordered eating, whether it's binge eating or overeating, that is biologically driven as a result of the social factors. We also can think about people who don't have great healthcare access, maybe not getting awareness on nutritional literacy, as well as access to preventative healthcare and coaching early on aspects of a life that are associated with better health, such as greater physical activity, better nutrition, but more importantly, treating and recognizing other health risk factors that could be modified and addressed early on in life, other co-occurring health conditions, for example. We also know that for people who are coming from more disadvantaged communities with limited access or poor socioeconomic supports, are less likely to engage in obesity care, which further perpetuates the development of obesity and lack of treatment for obesity, which can lead to further complications and poorer quality of life. We know from studies for patients who are going for bariatric and metabolic surgery that they are less likely to proceed with surgery or complete the surgical pathways if they are from Black, South Asian, or other minority groups, if they come from lower socioeconomic status, and also have lower education as well. And so all of these factors contribute to navigation through the system, which might be difficult, and poorer access. And of course, financial barriers limit both access to psychological treatments, to pharmacotherapy, and also for surgical interventions. And so what we need to do as we're considering obesity care in a more health equity focused way is to assess for and identify barriers in terms of social and structural determinants of health, advocate with our patients for policy changes, which could be access to medications, meal replacements, vitamin coverage, for example, for people undergoing metabolic and bariatric surgery. And then also thinking about the diverse communities we serve and developing culturally competent, personalized care approaches that factor in and connect with our patients in terms of their cultural backgrounds and how that might play out in terms of their treatments and treatment plans. And so again, there's an education component and awareness that we need to build within our obesity teams and clinicians.